Welcome back, everyone. We're going to continue on with the neonate and newborn series with taking a look at complications and emergencies associated with the newborn and the neonate. This will be a two-part lecture as the content's fairly extensive and we need to have some discussion on some of these that are more involved than can be covered in a single lecture. First of all, let's talk about acidosis. So we want to suspect metabolic acidosis if bradycardia presents or is persistent in the newborn, even after adequate ventilation, chest compressions, and volume expansion. And we'll divulge into this further with neonatal and newborn resuscitation here in just a bit. But post-resuscitation attempts, if we're still suspecting or we're still seeing bradycardia, then we want to consider the possible presence of acidosis. With acidosis for advanced level providers, consider administering a bolus of normal saline to help improve perfusion and help maintain or dilute the presence of acid. The best treatment is to identify and correct the underlying causes. So taking a look, and this will require transport and further assessment and evaluation than we have the ability to do within the pre-hospital world, but a fluid bolus is a good way to start there. Pneumothorax is a complication of childbirth that can result if the infant inhales meconium or if the lungs are potentially weakened by infection. In any case, treatment of pneumothorax is the same as if it were a traumatic pneumothorax or a spontaneous pneumothorax. Signs of significant pneumothorax are going to be severe respiratory distress that's unresponsive to positive pressure ventilation with unilaterally decreased breath sounds. For pneumothorax, we're going to, for a tension pneumothorax or a pneumothorax in the state of resuscitation of the newborn, then we're going to want to decompress. So make sure we clean the area with alcohol. Prepare your equipment, the appropriate sized equipment for the neonate. We're not going to be using large adult-sized catheters here for decompression. We'll insert the needle above the upper edge of the second rib. And if symptomatic, the ongoing air leak can occur, you may need to insert a 22 gauge angiocath just to the alternate side of that, so you may have to rotate sides. Remember that chest decompression is only good for usually about 3 to 5 minutes, and then the body's natural immune response is either going to collapse that catheter or potentially occlude that catheter, so you may have to re-decompress. A decompression is not a once and done. For meconium staining, this carries a high risk of morbidity. If newborns inhale meconium-stained amniotic fluid, the airway can become plugged. This can result in atelectasis or the collapsing or the failure to inflate the parenchyma of the lungs. Persistent pulmonary hypertension, hypoxemia, aspiration pneumonitis, as well as a pneumothorax. So we should note meconium staining during childbirth and prepare. Every OB kit is generally equipped with a meconium aspirator, and we'll talk about that here in just a second. We want to decrease the risk of pulmonary hypertension by clearing that airway and keeping newborn warm, right? Minimize stimulation so we don't deeper inhale the meconium until after we've been able to have a chance to remove the meconium through the meconium aspirator. The image that you see here on the screen is a meconium aspirator. It attaches, one end attaches to the suction. The other end attaches to either a very small endotracheal tube, so we're looking at like a 2.5 here, size 2.5 or size 3 endotracheal tube. Some commercial devices come with a suction catheter that is pre-packaged with it to be utilized, but most commonly you see it attached to a 2.5 uncuffed ET tube. For depressed respirations, post-meconium staining, you want to start positive pressure ventilation. And then what we're going to do with the meconium aspirator is we're essentially going to intubate with the meconium aspirator and then withdraw the intubation while suctioning. So we're going to re-intubate and suction, rinse in between, and positive pressure ventilation is required in between until we can get the majority of the meconium out of the airway and we're getting adequate gas exchange. If the newborn's not responding well, then we probably need to start moving down the neonatal resuscitation algorithm. And again, we've got a separate lecture that will discuss those steps there. Suspect airway occlusion or a pneumothorax if baby doesn't improve post suctioning of the meconium and continued oxygenation and ventilation. Remember, the cornerstone of care in newborns is preventing hypothermia. Keep these babies warm while you're working on this and reassess them frequently. For low blood volume, fluid resuscitation may be needed as part of fluid depletion. This can be due to many causes: abruptio placento, twin-to-twin transfusion, placenta previa, or septic shock. You should assess for hypovolemia or low blood perfusion, just like you would in a neonate, just like you would in any other patient. Things like persistent pallor, persistently low pulse rate, weak pulse, or no improvement in circulatory status post-childbirth. In the newborn, you can place a low umbilical vein line. We generally don't cannulate umbilical cords very often any longer. That used to be more common practice, but with the advent of and the prevalence of intraosseous infusions, it generally is a much better way to perfuse baby and to establish a line that's well equipped. If you have a neonate who's more than a few days old, place a peripheral IV or IO line, like I mentioned, and consider administering a fluid bolus. You can cannulate the umbilical cord, and we'll go over in lab what that looks like in that process. A diaphragmatic hernia. This is an abnormal opening in the diaphragm. Postnatal signs include symptoms like respiratory distress. Heart tones may be shifted to the right. And bowel sounds may be heard in the chest. In reality, this is really difficult to discern in the pre-hospital world. Look for a presentation similar to a pneumothorax, and this is going to be a very similar presentation as you get. You're going to have a very hard time differentiating between a pneumothorax and a diaphragmatic hernia. With diaphragmatic hernias, it's rarer that the entire left side of the chest there is filled with bowel material. It's usually a smaller amount, so it's usually not a circulatory problem, but be aware and assess accordingly. For assessment and management, there's not going to be a whole lot you can do with a diaphragmatic hernia. Resuscitate on 100% oxygen, right? Which if they're hypoxic, then let's go. We'll talk about that with neonatal resuscitation. You're going to withhold oxygen initially because of that transition from fetal circulation to individual circulation. We don't want to oxygenate them super early, but if we are down in the throes of neonatal resuscitation and we're having absent lung sounds on the left-hand side and baby is continuously not improving, then we're going to escalate that up to make sure that we're oxygenating that patient. Monitor heart rate continuously, and ultimately this is going to require a surgical correction. Single most cause of respiratory distress and cyanosis in the neonate or the newborn is going to be early childbirth, born too soon, prematurity. Respiratory causes can be delayed fetal transition. Remember, that's that transitioning from fetal circulation to individual circulation, the closure of ductus arteriosus and the other two. CNS depression is also a cause. Septic shock or metabolic acidosis can be of concern, as well as cardiac abnormalities, which we'll discuss again in a subsequent lecture. For assessment and management of these patients, ensure the airway is patent, check breathing, make sure it's adequate, verify pulse, assess respirations, and ask about increased symptoms with feeding if you're into the neonate world and out of that newborn realm. Assessment and management include, ensuring patency of the airway, right? Adequate oxygenation if they are hypoxic, effective ventilation, and ensuring circulation. Respiratory depression secondary to narcotics. As we are all well aware that the prevalence of opiates transcends borders, classes, everybody. This is not an uncommon cause. Again, while childbirth is progresses relatively normally and complications are fairly rare, when we see complications of childbirth or complications to the neonate, this is one of the more prevalent concerns that we need to be worried about. History is going to be important here. Baby's going to can present exposed to narcotic use, they can present in full withdrawal symptoms because as they've separated from maternal circulation, they've no longer, hopefully, been exposed to the narcotics. So you need to be prepared to manage accordingly for respiratory depression or fetal insufficiency or newborn insufficiency secondary to suspected narcotic or opiate use. Specifically, we can consider the use of naloxone. It also may precipitate seizures and can cause problems. So withdrawal symptoms are going to be something to be aware of here. And naloxone is no longer recommended for the first-line drug in resuscitation because of some of those associated complications, such as seizures and pulmonary edema in the neonate patient. For respiratory depression from mom's chronic use, right, provide ventilatory support, transport immediately. If we can adequately ventilate and oxygenate the patient accordingly, then that's the route we're going to go with the neonates prior to administering any medications. If required, we can do naloxone. Again, it can be given intravenously, intramuscularly, intraoscularly, or intranasally. Preferably in the neonate patient, intranasally is a little bit easier to manage with these patients. So you may consider the use of an intranatal nasal atomizer. Premature and low birth weight in infants. So premature is when baby is delivered prior to 37 weeks of gestation. There are some associated complications with this, including an increased mortality rate. If you'll recall from neonatal development that the lungs are some of the last to fully function, and the secretion of surfactant doesn't occur until the mid-30s weeks. Which is the chemical that keeps the lung from sticking together. So there's associated complications with premature specifically, and then low birth weight additionally. Low birth weight is defined as an infant weighing less than 5.5 pounds. Morbidity and mortality for this are really related to the degree of prematurity. If it's low birth weight and a full-term newborn, then the likelihood of complications are less than if they're early. To determine prematurity, you're going to need to rely on physical features and then information about gestational dating, information related to maternal and fetal complications. You should be inquiring about prenatal care, prenatal supplements, gestational age. Mom usually knows if she's engaged in prenatal care, the gestational age or how long she's been pregnant. But there are times where you can encounter patients where mom didn't know she was pregnant, and there may be no indication of gestational age, in which case you'll need to rely on fetal development and assessment to get the relative age there. To optimize survival in the field, provide cardiorespiratory support when needed, right? Thermal neutral environment, keep baby warm. I know we say this a lot, but it's a really important thing to remember. And use only minimum pressure necessary to move the chest when providing positive pressure ventilation. Overinsufflation of the lungs. Neonates are super subjective to thoracic trauma and barotrauma. So if we have to provide ventilatory support, minimal amounts of pressure, just enough to a little bit of chest rise. Further assessment and management, make sure airway is clear, right? Gentle stimulation, supplemental oxygen, and positive pressure ventilation if needed, and providing chest compressions again if needed, and then maintaining that warm environment.